Thank you so much for the introduction. At the outset, thank you to Vijayakumar sir for this opportunity to be here today. Muruganathan sir, so many colleagues and friends are in the audience, and it's a perfect timing to talk about fasting just before lunch. So, so I won't take too long. I'll try in 13 minutes to finish as fast as I can. So intermittent fasting is defined as any meal timing approach that alternates eating and a fasting period. So usually, don't worry about the time here. Now there are many types of intermittent fasting. The first one is fasting 1 day a week. So out of 7 days, you eat normally for 6 days and 1 day you fast. The second one is alternate day fasting. 1 day normal eating, 1 day fasting. 1 day normal eating, 1 day fasting. Now during this fasting period, what is it you're doing? You actually have an option of going from 0 to 500 calories. So 0 calorie means only water, or you can have green tea, you can have black coffee, or 0 calorie beverages, sweetened beverages. So any of these are in your 0 calorie area. Up to about 500 calories is allowed for that. Now you have also what is called, so this is alternate day fasting. Now if you add that 500 calorie option, it's called alternate day modified fasting. So if you're actually on 0 and ad libitum means eating whatever you want. So eating whatever 0 is alternate day. If you add the 500 calorie to it, it becomes the modified alternate day fasting. Then you have the 5:2 diet, where 5 days you're doing ad libitum and 2 days you do the fast in this manner. Now in 5:2, they allow about 500 to about 1000 calories. So that is the 5:2. So this is one of the easier ones to do, because actually 5 days you're not fasting, 2 days you're fasting, and up to 1000 calories is allowed in that particular diet. Now the next one is called fasting mimicking diet. So what does this do? This again allows, it's a particular diet that you do for 5 days a month, once a month. Now on day 1, you're allowed 1100 calories. On day 2 to 5, you're allowed 750 calories. So it's a kind of intermediate. 1100 one day, 750, total 5 days, stop. Repeat next month. Repeat next month. Like this, they try to do this fasting mimicking diet. All of these were the different types of fasting. Then you have what's called as time restricted eating. Now in this particular thing, you're not looking at calories. So you're not saying how many calories, in all of these I talked about 500 calorie, 1000 calorie, 1100 calorie, all that I said. In this particular segment, you're not looking at calories. You're only looking at time. So you have an eating time and a non-eating time. The minimum here is 12 hours, and I'll tell you why. But you have to, in order for it to go into a time-restricted eating, you need to do 14, or most popular one is 16 hours of fasting. So let's look at that in a little bit more detail. Now how does this work? When you have periods of energy restriction, you have depletion of liver glycogen stores, and in about 12 hours, from the fasting, they undergo something called as a metabolic switch. So you stop using glucose and you start using fatty acid and ketones for fuel, which is what you're trying to achieve when you go through this fasting stage. So what happened at the cellular level, there's a stress mode that goes into, and overall everything starts going down, your insulin signaling, protein synthesis, etc. But then you have a recovery period. So the next day when you start eating again, the glucose levels go up, ketone bodies come down. The increase in protein synthesis, repair, growth, this is what you want happening. So this period of fasting and recovery, this is the one that helps you to kind of lose weight. That ketone body cycle, then the protein recovery, all of this is the one. Now in addition to this, if you add some exercise and all that, you have a lot of beneficial effects. For the want of time, this is not moving. For want of time, I'm not going into the details of any of the physiology, but let's look at the evidence of what and all can happen if you do intermittent fasting. First, let's look at intermittent fasting and obesity. This is a study we did with Cheryl Salis in Mumbai, and we tried to look at the role of intermittent fasting in weight loss, that is just body weight reduction in obese adults. This was actually done in her clinic, and I must thank her for these slides. So she took 32 overweight and adult Indians and tried the intermittent fasting plan on them. So there were various different plans that she formed. Mostly it was time restricted eating, and most people did about 14 hours of time restricted eating. Some people did 12, some people did 16, but mostly it was time restricted eating that everybody followed. And was she able to see any beneficial effects? There were some astounding decreases in weight and the waist circumference, and this was more pronounced in females than it was in males. So this was one of the first studies that we started doing here to look at whether intermittent fasting was making a effect on body composition. But here you have data from a number of studies from across the world. That is, and look at the top, I'm going to show you a series of graphs. This is a forest plot. So all you need to look at is, this is the kind of meta-analyses. They take every study and they put the final synthesis outcome. So if this is null, this is favoring the intermittent fast. So here what they've done is, they have taken calorie restriction, okay, which is your 1500, 1100 calorie, and they've then added the intermittent fasting. So if it's on this side, then mean it favors calorie restriction. If it's on this side, it's intermittent fasting. This is for body weight, okay. So look at body weight. It did have a beneficial effect. A lot of studies did have the effect, but it managed to touch null. Now look at BMI. BMI is null, no effect from the overall studies that are here. Now look at lean body mass. Lean body mass is favoring intermittent fasting plus thing. You see that lean body mass is actually favoring. Now look at fat mass. This is standing separately, completely. So this is the most significant effect that they found in intermittent fasting, that you have a decrease in the fat mass in kg, and this is the fat mass percentage. So we are showing benefits that are happening with intermittent fasting, and if the visceral adiposity goes down, your waist circumference also goes down. So this is one set of graphs that are looking at obesity here. This is for time restricted eating. The other one was intermittent fasting. This is time restricted eating. Again, whether it is showing benefit on body weight, yes, there was a significant benefit shown here in body weight in this one. So 8 hours TRE induces about 5 kg loss per year. So in this RCT, 90 people with obesity, three things were done. One is control. And this is weight over a period of a year. Nothing happened in the control, okay. Then this, if you look at it, it is time restricted eating, okay. So you can see it coming down, and this is calorie restriction. So both of these, there were no significant differences between these two. Both of these helped. So far, where have we got? In an obese person, weight, body fat, waist circumference, all these three are beneficially affected. Now let's look at diabetes. In type 1 diabetes, we often have a lot of worries about fasting because we think about ketosis, we think about hypoglycemia. But in this study, what they've shown, this is from Kuwait, they show that actually up to 36 hours, type 1 diabetics can fast. The ketones go up and then they actually come down after prolonged fast. The only thing one has to do is actually take the insulin into consideration. Similarly, a lot of type 1s do choose to fast. This is especially during Ramadan. They do intermittent fasting. 86% of people reported doing intermittent fasting. Now, what about type 2 diabetes? Now, for type 2 diabetes, again here this study is on 75 people with type 2. They have control, the usual diet. Calorie restriction is 25% energy restriction, and 8-hour TRE means 16 hours fasting. That's what it means. Now, what happens to body weight here? This is not moving, sorry. This is not moving. It's not moving. So, it's not moving. என்னங்க எங்க இருக்கு இல்லையே this is only a pointer. Oh, here. Okay. All right. So, sorry. Slide changer is not working either. Move avla sir. idhula na oru vaati thatti irukuma. Okay, so here you have the effects of that. So the effects on weight, you'll see that the control did not lose much body weight. The best was for the time restricted, sir. The best was for the time restricted eating. compared to the control. So this is in type 2, where again we found that calorie restriction and time restricted eating both had beneficial effects on body weight in those with type 2 diabetes. Now what about A1C? Again, there was no difference between the TRE and the controlled calorie restriction in terms of the A1C as well as the glucose. There was up to a 1% decrease in A1C. But the problem with all of these is that you have to do it for a prolonged period of time, minimum 3 months. So the best effects come in 3 months, up to 1 year. After that, it starts waning off. Now let's look at the fasting mimicking diet. I already told you that the fasting, what it was. So if you look at that one, you can see that compared to control, at 12 months, there was a significant drop in the A1C. It's the first in the 3-6 months, you have the fantastic drop that comes, and then after that, it goes up a little bit, but it's still statistically significant. Here's a meta-analysis done by Dr. Joshua Chadwick from NIE that looks at the safety and efficacy of intermittent fasting in those with type 2 diabetes. Now again, you can look at this thing here. It is definitely significant both for A1C as well as fasting plasma glucose. You can see that it is moving. It is also change in weight and BMI. So what they say here basically is that whether you do an intermittent fasting, whether you do a time restricted eating, they are both equivalent in terms of metabolic benefits for weight as well as glucose reduction. Now what about lipids? Actually, there's not much data on lipids and it's not been favorable much. There's a little change in HDL and VLDL, but this is primarily for those who do exercise. So it's not due to the fasting per se. I think it's more due to the physical activity, not much data on lipids. Now what about analysis on blood pressure? Time restricted eating did have beneficial, you can see the diamond is on the favoring side. It did have some beneficial effects on systolic as well as diastolic blood pressure, but there was variability in various studies. So putting everything that I just said together, if you take, so what I've told you so far is that calorie restriction and intermittent fasting both work. You choose what works for you. There are various ways of doing it. Whatever suits your mindset, you do it. What are the benefits you're getting? The benefits are primarily in weight and body fat. You have some benefits on glucose, A1C and fasting glucose. You have a lot of change in oxidative stress, null for inflammation, very good changes in body composition. So this is what we did so far. Now, what about the risks of intermittent fasting in people with diabetes? There is a definite risk of protein energy malnutrition, or there can be micronutrient deficiencies, vitamin and mineral deficiencies. This has come out especially in the longer term, more than 1 year studies. This is something one must look at. The other thing that can happen, there is commonly reported dehydration. So this can come as syncope, dizziness, headache, weakness, irritability, gastritis. All of this depends on the type of fasting that we are doing. So one of the important things, and increased risk of complications, there's not too much evidence on that. So one of the things that we have to do is do the sulfonylurea and insulin adjustments. So this is the OHA adjustment when you're doing different types of, it doesn't matter which type of fasting you're doing. If the A1C is below 7 and you're starting one of these regimens, then it's better to take care of the secretagogues and insulin. So sulfonylureas, DPP-4 as well as insulin, try and decrease by about 30% before starting any of the regimens. Now if you're doing alternate day fasting, on the day of fasting, please avoid all the secretagogues as well as the basal insulin. If A1C is between 7 and 10, then what you can do is, you can, on normal days, they can have normal medication. On fasting days, the secretagogues, sulfonylurea, those with highest risk of hypoglycemia, those ones you stop, and you try and give only prandial insulin. As and when they are eating, they're only taking about 500 calories. So only at that time you give accordingly. If the A1C is above 7, keep the insulin going. Only basal long-acting insulin you decrease. And that's what it says here as well. Things like metformin, AGI, pioglitazone, all of these things, and GLP-1 do not need change during this period. Who are not candidates for intermittent fasting? pregnant and lactating women, very young children, very old, elderly, frail people, those who have brittle diabetes, be careful, it will swing. Those with eating disorders, please note that one thing that comes out of these things is that it can push somebody into eating disorders. So if someone is already having that, be careful. Patients in an immunocompromised state, those with dementia or other serious medical conditions, CKD, DKD, etc. So novel and safe techniques have emerged for intermittent fasting. The key here is monitoring and education. So you can monitor using a CGM, you can monitor using a BGM. You have to educate the patient, track the glucose, track the ketones, things like that, adjust the medications, and if you do this, intermittent fasting can definitely be safe. So what are the pros and cons? Pros: weight loss, fat loss, enhances insulin sensitivity, blood pressure and lipids, lowers inflammation and cellular repair, and potential cognitive benefits. It's simple and practical, especially for time-restricted eating. There's only one instruction you give the patient: start eating, stop eating. Finished. In between, whatever they do doesn't matter. So time-restricted eating works like that. Cons: hunger, irritability, dizziness, nutrient deficiency, not appropriate for everybody. Long-term research, we don't have evidence, and we don't know what happens to lean body mass. So I'll conclude by saying, if you synergize traditional diabetes treatment with intermittent fasting, you may have the following benefits: improved glycemic control with weight loss. Everybody wants that, right? And it's so easy to start a drug. But if you don't want to start a drug, this is the most natural way of doing all of this: improving body composition, lowering risk of complications, improving self-control, compliance, and insulin sensitivity. So if properly adhered to, intermittent fasting can be an effective and safe tool in the treatment of diabetes and obesity. Before starting any regimen, people with diabetes should do it in a professional manner. Now we have all kinds of apps saying all kinds of things. Better always to do baseline testing, consult a physician before starting. It's always done with a dietitian as well as a doctor to look at medication adjustments, glucose monitoring, and fluid intake, and one must be aware about the side effects as well. Thank you very much.